And I are the co-facilitators for this session. My name is Veronica Yank, and I'm an associate professor of medicine in the Division of General Internal Medicine, faculty within the Multi-Ethnic Health Equity Research Center, among other things. And I'm just so excited to hear about your work today. So, and then I'll have Terry, why don't you introduce yourself, and then I'll just set the few ground rules that we have for today's session.
Awesome, thank you, Veronica. Hi, everybody, my name is Terry Yang. I am a graphic designer here at UCSF, and I work for the communications team in the Office of Diversity and Outreach. My pronouns are he, him, his.
Yes, and my pronouns are on the screen, she, her. What I'd like to do, if it's okay, is for each presenter to state their name before they present so that I do not butcher your respective name. And then each presenter has, I'll be the timekeeper, 5 minutes to present their work. And then there's a 1 minute for questions. I think what I may do, given the tight time, is have you all write your questions for a given speaker in the chat, or you can also just kind of jot them down and wait for the time after, and we'll have directed questions to the speakers at the end of the session. I'm just a little bit worried about timing, but you could put in questions for Ashley and then put it in chat, and Terry and I will hold it to the end and then figure out how to manage time at the end. All right. Okay, Ashley, please take it away.
Perfect. Thank you so much. So my name is Ashley. I'm a current third-year pharmacy student here at the School of Pharmacy, and I'm joined by my faculty advisor in the audience, Dr. Leon. And today we're going to talk about our efforts to address the opioid crisis during the pandemic using a hybrid, multi-center, interprofessional opioid overdose prevention workshop. Okay, so just to give a little bit of background on the crisis during the pandemic, there were over 100,000 deaths in the US in the first year alone, with the number of deaths increasing due to recreational abuse of opioids. And what we saw in this was a change in daily life for all of the users, including interruption of medical treatment or care, disruption of routine, loss of work, etc. And additionally, we found that those who were using were also more susceptible to COVID-19, but just because it affects our respiratory health. So to take a look at how this impacted our own communities, in San Francisco, they notably had the highest opioid overdose death rate in California, with 3/4 of the deaths due to fentanyl. And in terms of Fresno, the causes of deaths were notable for methamphetamine, fentanyl, and heroin. So with this increasing incidence of opioid overdose, there's clearly a need to better train all of our healthcare providers on how to respond to an opioid overdose appropriately. And now many of our health professionals, before we start school, we are required to complete the American Heart Association BLS training. But there is a huge gap in knowledge here because the BLS training does not include hands-on training on how to use naloxone, and just a little TLDR on what naloxone is itself. So our research question was, how does a hybrid, synchronous, multi-center, interprofessional workshop promote learning and influence participants' attitudes towards opioid overdose? We designed a workshop that focused really on providing this hands-on training that I referred to earlier in response to overdose. And our design was modeled after a previous workshop in 2020. The biggest difference between our two workshops was that the original workshop was only virtual, whereas for our workshop this past year, we were allowed participants to choose if they wanted to attend either virtually or in person. And the in-person workshop was held at Mission Bay, so local for us. Going over our workshop schedule, I just wanted to point out some of the activities we had included, which were an IPE discussion on implicit bias and stigma, a review of the signs and symptoms of opioid overdose, and there was a designated time to actually practice how to respond when suspecting an overdose and how to administer as well. So we targeted, of course, health professionals, across, those who were affiliated across both of our campuses at UCSF and Fresno State. And participants were given the opportunity to complete a pre and post workshop survey. These validated surveys, the first one was the OOKS, or the Opioid Overdose Knowledge Scale. And that was really geared toward assessing like knowledge of opioid overdose, including things such as risk factors, signs of an overdose, what to do in that situation, naloxone's effects and how to administer it, and the aftercare. The other survey, the OOAS, which covered opioid overdose attitude scale, really was to sort of evaluate the healthcare providers' attitudes towards managing an overdose. And we did so on 3 subscales, including competence, which was ability to manage the overdose, concerns with dealing with an overdose itself, and then readiness, like would they be able to respond? And to quickly recap last year's results, we found that all of our pre and post surveys showed categories were improved except for readiness. Okay, so going over the results from our own workshop, we found that, again, similarly with our previous workshop, we had improvements in all categories excluding readiness. And I wanted to point out that in our last workshop, we had almost an even number of participants who were in person and virtual. And I think that this really enforced the data, or what we learned from last year was that naloxone readiness is something that really needs to be taught in person, whereas you can gain like skills and the comfort level to actually be able to respond in person. And those are some things that we might not be able to deliver over Zoom. Okay, and now I just wanted to share a couple photos from our workshop itself last year. As you can see, we had our first responders really demonstrating, coaching us, like our students, on exactly what to do, like with our hands. And I felt like that was, as a participant myself, I found that to be incredibly valuable and something that we can't replace. And now here are my references. So thank you everyone for your time.
Fantastic, Ashley. So everybody, save up your questions for Ashley and others. And to the end, as I said, and I forgot to mention that I will be putting up that little clock sign when you have 1 minute left. So sorry to not prep you for that, Ashley, but you were right on time. Okay, so we are happy to now welcome presenter number 2, Frank. Please introduce yourself. Thank you.
Hello, everyone. Oh, can everyone hear me? Okay, perfect. All right, my name is Frank. I am a research associate at the Center on Substance Use and Health. I will be presenting my poster today, and if I can share screen. Can everyone see this okay? Yeah, perfect. Alrighty. So just to start off, I would like to say that I am Frank Lee. I am a researcher at the Center on Substance Use and Health, and I'll be presenting stimulant use associated with psychosocial factors, HIV risk, and current hazardous alcohol use among US adults recruited via an online crowdsourcing platform. So just to give a bit of a background, stimulant use is defined as meth use, crack, cocaine, and cocaine use. It's a major public health problem that contributes to high morbidity and mortality among US citizens, especially among men that have sex with men, also known as MSM. There's a need to better understand the factors that are associated with stimulant use in order to help us inform prevention and treatment interventions for people who use stimulants. And the objective of our study was to identify the correlates of stimulant use among individuals recruited in Amazon Mechanical Turk, which is an online crowdsourcing platform. And what we did was we recruited 272 individuals to complete a baseline survey. Participants greater or equal to the ages of 18 in the United States who reported any alcohol or stimulant use were eligible to participate and were recruited using MTurk. Participants then completed a baseline survey, which assessed social demographics such as age, race, and income bracket, psychosocial factors such as depression and negative affect, positive affect, self-esteem, substance use such as alcohol use, stimulant use, and cravings for substances and alcohol, and finally sexual risk behaviors such as number of sexual partners and history of being diagnosed with an STI. After we collected the data, what we did was we built bivariate and multivariate logistical regression models to identify the correlates of substance use. And in our models, what we did was we found the total effect of each exposure on stimulant use with one exposure per model. And so drawing the data from the bivariate logistical regression models, we can then build the multivariate logistical regression models by controlling for age, race, health insurance, and relationship status. Additionally, we also took each model and we stratified by MSM status. So as you can see on the screen, we have a total column, which is everyone in the data set. We have the MSM column, which is just MSM. And then we have non-MSM, which is everyone that is not MSM. And then additionally, we also wanted to test specifically negative affect, which is an indicator of emotional disorder, as a moderator of stimulant use among MSM by estimating the relative excess risk due to interaction using an additive scale. So basically, we're trying to see if negative affect and MSM status together had an additive effect on stimulant use. So moving on to the results, we had 272 total recruited participants, 75% identified as male, around half were MSM, and around 20% were from racial and ethnic minorities communities, and about half of them were in relationship. Around 15% of the participants reported stimulant use in the past 6 months. And then factors that are associated with stimulant use in our data set were MSM status, audit C, which is hazard alcohol, which is a measure for hazard alcohol consumption, day level cravings for alcohol in the last 24 hours, depression, number of male partners in the last 6 months, number of female partners in the last 6 months, and then being diagnosed with any STIs in the past 6 months. Two interesting results that I would like to highlight is that we did not find perceived stress to be associated with stimulant use in our data set, which is interesting because of previous literature has documented this relationship between stress and stimulant use. However, because we have just a baseline data, we perhaps did not capture the temporality that stress can have on stimulant use, and so future studies should focus on that. Additionally, we also found that negative affect was not associated with stimulant use in the total population. However, it was in the MSM population. So negative affect is a factor in MSM uses stimulants. Additionally, there was a significant additive interaction between MSM status and negative affect, with MSM with greater negative affect reporting more stimulant use. Overall, our results from our study suggest that there's a need to address alcohol use, cravings for alcohol, sexual health, depression among people who use stimulants, and especially our study also shows that MSM experience a greater burden of stimulant use and that there should be a focus on the MSM that have greater negative affect in order to reduce the burden of stimulant use among this population and improve the health of everyone who uses stimulants. I would like to thank my mentors and all the participants who made this research possible. This has been an incredible experience, and that is the end of my presentation.
Wow, you guys are on time. Fantastic presentation, Frank. Thank you so much. And again, hold your questions for Frank. And we at this point will welcome to the screen Shivani. And Shivani, please correct my pronunciation.
No, you pronounce it correct. It's Shivani.
Sorry, I went too far.
Totally fine. I'll quickly introduce myself. So, hi everyone. My name is Shivani Mehta. I am a second-year PhD student in the Epi and Biostats program. The work I'm presenting today is the work that I'm doing with my PI, Dr. William Brown, as a graduate student researcher with the Code Lab, where Dr. Brown's mission is to use user-friendly informatics tool for social disparities research. So employment and housing insecurity are associated with an increased risk of opioid-related disorders and disparities of health outcomes. And our goal was to compare employment and housing documentation among patients with opioid-related disorders in structured data, which are traditional diagnosis code tables from EHR data, and unstructured data, which are clinical notes. And so we use two novel user-friendly bioinformatic tools, which is Patient Explorer, to help us identify and extract our cohort through our de-identified CDW at UCSF as seen in Figure 1, and Immerse, which allowed us to extract and analyze clinical notes using natural language processing. So we created Immerse NLP rules as seen in Table 1 for each domain using the Compendium of Medical Terminology Codes for Social Risk Factors as our language resource to identify strings, stems, roots, and syntactic similarities. We then looked at clinical notes of our cohort in Immerse using our Immerse NLP rule to see how many clinical notes have documentation of problems related to employment or housing insecurity. We manually validated the clinical notes to verify that the NLP rule mapping was correctly classifying the social risks. And so example of classification is seen in Table 2. So when a patient was deemed as a true positive for problems related to employment, if they were unemployed, laid off, looking for employment, worried about their job, etc. And then true positive terminology for housing included a patient having unstable housing conditions, dealing with eviction, unsafe housing conditions, or homelessness. So our patient cohort included 1,111 adult patients with ORD outpatient medical encounters at UCSF Health from January 1st, 2018 to December 31st, 2019. And then within our structured data, 2 patients out of the 1,111 had ICD-10 Z56 diagnosis code for problems related to unemployment, and 155 patients had ICD-10 Z59 codes related to housing insecurity. And as seen in Table 3, the Immerse positive column specifically, Immerse identified a total of 216 patients with documentation of problems related to employment and a total of 462 patients with documentation of housing insecurity. So our employment NLP rule achieved 100% sensitivity when compared to the structured data, and the housing Immerse NLP rule achieved a 93.5% sensitivity. So our goal was to develop an NLP rule for each social determinant of health domain that was highly sensitive to the SDOH classification. We then manually reviewed all the patients with clinical notes in Immerse deemed as positive for having documentation of the SDOH, but did not have the ICD-10 code documentation within their structured data. So for the employment domain, as seen in Table 3, this is the 214 patients. And for the housing domain, this is the 317 patients. So manual review of the clinical notes validated that 178 of the 214 patients had documentation of employment hardship, and 119 of the 317 patients had documentation of housing insecurity. So overall, our study revealed a higher prevalence of social determinant of health information from a patient's clinical notes compared to their structured data. And the usage of these novel user-friendly tools like Immerse and Patient Explorer will allow this type of descriptive work to be conducted if researchers don't have any prior expertise in coding or natural language processing. And application of this technique in different health domains or social determinant of health domains may inform clinical decision-making and help reduce health disparities. Thank you.
Fabulous. You were under time. That was wonderful work, Shivani. And I know we're going to have questions for everybody at the end. And I see we're already loaded with the next presenter. And Young, let's have you introduce yourself, please.
Thanks, Veronica. Hi, everyone. I'm Young Nguyen. I'm Assistant Professor of Division of General Internal Medicine at the School of Medicine at UCSF. And it's my pleasure today to present our research about the young adult, sexual minority young adults, and tobacco use. First of all, I want to shout out to my co-authors who helped with this poster and also the manuscript under review right now. So let's give you some brief background about the tobacco use among sexual minority population in general. The recent meta-analysis show that the sexual minority populations have the double rate of tobacco use compared with the heterosexual. They have a lot of different hypotheses to try to explain that. And the most prominent one is about the minority stress, that people experience a lot of the marginal stress and they use substance use, especially tobacco, to cope with their stressor. However, we still like finding the way to help them to quit tobacco. And in the literature right now, we have the limited understanding about the perception of tobacco use, especially in the variety of different types of tobacco products, because currently the literature focuses on cigarette smoking. However, for young people, they not really use only cigarette, but they use different type of tobacco, especially the e-cigarette, the new version of tobacco. So that's why we conduct this study to examine the association between the sexual identity and the perception of the variety of tobacco products among young adults. And we use the cross-sectional data in San Francisco Bay Area, recently collected during the pandemic. We have the 310 young adults with the mean age around 23 years old. Half of them is females, and we have the diverse group of racial and ethnicity. The main measure of the outcome perceptions measure as the Likert scale from 1 not at all harmful to general health to extremely harmful for each tobacco product. And we use the linear regression model to examine whether the sexual identity have the relationship with the outcome for each of the perception of the tobacco product, control for the demographic covariate, and also control for tobacco use. So in the key finding in the middle of the slide, you can see the mean score, the description of the mean score of all of the tobacco products perception is lower among sexual minority compared with the heterosexuals, and it's significant. And in general patterns, the highest perception of harm is for cigarette and the lowest for e-cigarette. That is consistent with the literature. People think that e-cigarette is kind of like the harm reductions without insufficient information about the harm and benefit of e-cigarette. And the second underline of the key findings show you the result from the regression model. That is beta coefficient and 95 confidence interval. So all of the negative value indicate that the sexual minority people have the lower harm perception compared with heterosexual after controlling for the covariate. So what's the conclusion of this basic findings? Is just showing that the sexual minority young adult perceives tobacco use is less harmful than heterosexual peers, regardless of tobacco products. So the implication is that we need to target to the harm perception, not only focus on cigarette, but focus on all type of tobacco and nicotine use to reduce the tobacco and nicotine use in these populations. And the education campaign should focus on create some messaging about harm perceptions and especially target on the new tobacco products, such as e-cigarette. Thank you for your listening.
Wonderful. Thank you so much. I'm learning so much. All right. And you guys are staying right on time. So I think, let me see our final presenter, Mukund. I am afraid I am butchering your name. I know you had to jump on a little later than the rest, but we are hoping you are ready to share your screen and present with us. And please introduce yourself, and it'll inform me about how badly I butchered your name.
You're totally fine. My name is Mukund, he, him pronouns. I worked with the BHHI, the Benioff Housing and Homelessness Institute, over the summer, looking at some of their data on methamphetamine use as part of the California state study on homelessness.
Oh, and I did, okay, somebody kindly told me that I messed up the order, so my apologies. Maya, I messed you up. We had last minute changes to the order, and somehow, oh yeah, I was gonna have Mukund, okay, it's the way, but Mukund, you're gonna go in your original spot. You're now back in your original spot because you got on early enough, and then we'll go to Maya, and then we'll go to Julia. Sorry, everybody, we had some last minute shuffling. So my apologies. All right, you're on.
No, it's all good. I had training to be at that I couldn't miss, and appreciate your consideration and switching up the order for me. It's nice to be here. Let me try and get this to be full screen, and then do some screen sharing wizardry. Can you see the full screen presentation okay?
Not yet.
It's
Oh,
not showing
okay.
up.
Great. It's coming.
It's
Seeing
good.
it now.
Okay, fantastic. All right, so I'll stay within my 5 minutes, but happy to talk to you about some of this really exciting data, which for the most part is still in its preliminary stages. We have a lot more data than this. We ended up gathering nearly 40 qualitative interviews just for the behavioral health sub-study of the California State Study, which I'll talk to you about. And so there's plenty more, and I hope to talk to you about this again someday when there has been more analysis and as we're closer to a final product. But as of now, I'm going to talk to you today about methamphetamine use among people experiencing homelessness in California. This is a subject that's very near and dear to my own heart. I was a case manager in a street medicine program for a few years before I started as a student at UCSF, and methamphetamine use was something that was pretty critical to patient care for almost my entire panel. And unfortunately, even as methamphetamine use rates are exponentially multiplying, both in the homeless population and in the general population, there remains a pretty severe lack of treatment and care for people who are wanting to wean off their methamphetamine use, or even just harm reduction methods for people who use meth. So we wanted to look at some qualitative data from the California State Study on Homelessness, which is a mixed methods, pretty large scale study through 8 counties in California that is looking at the state of homelessness as it exists across the entire state for people who qualify as having certain experiences, such as in this case, a history of behavioral health and or substance use. We did a semi-structured qualitative interview examining their mental health history and their substance use patterns. And we asked the following questions, in particular, what role does methamphetamine use play in people's lived experiences of homelessness? And how are existing policies, programs, and services in California meeting the needs of people who experience homelessness who are using methamphetamine? So as part of this preliminary analysis, we found a couple of themes. I'm going to share 3 of them with you today. Primarily, one being that people use methamphetamine to facilitate activities that are necessary for daily survival. And I have these really powerful quotes here. I'm just going to read some of them, not in their entirety. But this person says, I started using when I became homeless, a lot more doing meth. It's not good for you and it's damaging, but I would do it by myself in the streets to stay awake at night. I've seen a lot of bad stuff on the streets. We also found people use methamphetamine to foster social connection within encampments, particularly in group living situations, or between friends or between partners. One of our participants said, meth use is a social thing. I do it when we're sitting around and talking. This is like our family. And another one of our participants who engaged in sex work says, I'm popping myself. It's always social just so I can have sex when I go on dates. As you can see, these different categories do exist as discrete entities, but there's a lot of overlap between them in that people who use meth socially are also using it in a somewhat instrumental way, for example, in order to facilitate the activities they use to make an income or for social cohesion in their encampments. Finally, we talked about methamphetamine and mental health, which is a very broad theme. And so I've divided it into a couple of sub-themes, one of which is instrumental in the way that people are using meth to treat, self-medicate, as they would say, their symptoms of mental health, particularly ADHD. This person says, meth calmed me down. I could focus more. If I get high, I'll sit and focus. I don't fumble for words, none of that stuff. I can think. But on the flip side, as people are using meth instrumentally, some of them find that it exacerbates their mental health symptoms. For example, this person says, the meth makes my symptoms worse if I was to stay awake. And this is a callback to our instrumental use theme. However, as of now, I can still identify the hallucinations for hallucinations. So just to wrap up, all of these themes really point to the fact that methamphetamine use is shaped by the conditions that homelessness impose on these people. It is shaped by lack of access to housing, and people are using meth in a strategic response to unsafe and materially constrained conditions. And a key takeaway, of course, is that the lack of housing should be considered as a primary factor in harm reduction methods that are being implemented for this population. Thank you, everybody. It was a short 5 minutes, but I look forward to continuing this discussion with you in the future.
Yeah, and just so you know, since you had to hop on a little later, we were holding time for the end for questions. So I know people will have questions for all the speakers at the end. So I'm hoping everybody can stay on to field those questions about their work. So now I'm going back to the correct order and would like to welcome Maya to present.
Thank you. I'm also going to share my screen. And please let me know when that pops up for everybody. Okay, great. Sorry, my screen just froze, but let me give it a sec. Okay, great. So hi, everybody. My name is Maya Scarpetta. I am a second-year doctoral student in the UCSF Epidemiology and Translational Sciences program. I'm presenting today on injecting partnership interpersonal factors and their relationship to partnership needle sharing. And I do want to acknowledge that a couple co-authors of this poster are in the Zoom audience today. So thank you for attending. And excited to be presenting about this work today. So people who inject drugs experience a disproportionate burden of hepatitis C virus infection. And for people who inject drugs, hep C virus is transmitted through the sharing of needles, syringes, and ancillary injecting equipment, which are behaviors that involve at least 2 people. So although research acknowledges that these behaviors occur in the social sphere, little is known in terms of 1, quantifying relevant interpersonal factors that impact the social sphere and relationships between people who inject drugs, and 2, how interpersonal factors affect high-risk injecting behaviors that also increase hep C infection risk. So identifying how interpersonal dynamics of injecting partnerships affect high-risk behaviors is necessary to develop effective interventions to prevent hep C transmission. And the current analysis identified injecting-related interpersonal factors and measured their association with injecting drug use behaviors among injecting partnerships. This analysis was conducted using data from the Injecting Dynamics in Injecting Partnerships study, which was NIH-funded research done in conjunction with an extensive team across 2 study sites. The first was in San Francisco, California, and the second was in Montreal, Canada. The primary covariate were interpersonal factors that were measured using the Interpersonal Relationships Dynamic Scale, which is a theory-based measure of injecting-related interpersonal dynamics. It is a validated scale that has been applied to previous injecting partnership studies, and it contains 36 items with 5 partnerships subscales, which include trust, intimacy, cooperation, power, and risk perception. Recent partnership needle sharing was determined as a binary measure with a question in the baseline questionnaire. And partnership characteristics and demographics were measured, including partnership age composition, gender composition, and the number of non-primary injecting partners. We applied an actor-partner interdependence model, which is the statistical model of choice for dyadic data analysis. They measure the influence that 2 people have on each other, taking into account interdependence. So we applied this model using generalized linear mixed models. And we are interested in partnership dynamics. So we adjusted for partnership characteristics using covariates such as partnership gender composition and age composition, which also serve as proxies for other interpersonal dynamics such as power. And as with any observational study, our analysis had to account for missing data, which we did using multiple imputation. And we imputed missing values under the assumption that data are conditionally missing at random, and performed confirmatory factor analysis for each interpersonal factor. So drawing your attention to table 1, of the total 131 partnerships and 170 individuals enrolled, 48 of those partnerships were included in the analysis from the Montreal site, and 83 of those partnerships were included from the San Francisco site. In terms of our outcome partnership needle sharing, a majority of partnerships at the San Francisco site reported engaging in partnership needle sharing, and that was at 84.3% reported that outcome, but a minority of partnerships at the Montreal site reported this behavior. In terms of site-wide differences at the partnership level characteristics, partnerships in San Francisco were more likely to be under the age of 30. That was the main site-wide difference. And in terms of our results, after adjusting for partnership level characteristics, partnerships where one or both partners reported high levels of trust had elevated odds of engaging in partnership needle sharing compared to when neither partner reported high levels of trust. And a similar relationship was observed for cooperation. No significant results were observed for power and intimacy. And interestingly, an inverse relationship was observed for risk perception, where partnerships had lower odds of engaging in partnership needle sharing when one or both partners reported high risk perception. And that effect is demonstrated in figure 1, although I would like to point out that the scale is on a probability scale, not an odds scale, so it's slightly different, but the general message is the same, where the X and Y axis show the sum of partner risk perception and actor risk perception. And it shows that as those risk perceptions increase, the odds of partnership needle sharing decrease, or sorry, the probability of partnership needle sharing decrease. So in sum, our findings found that injecting partnerships had increased odds of needle sharing when both partnerships reported high levels of trust or cooperation. And the inverse relationship was observed for partnerships where both partners and only one partner reported high levels of trust. So basically, interpersonal factors contribute to partnership needle sharing, but the way that they influence needle sharing is very different depending on the interpersonal factor. And this is really helpful when thinking about interventions that incorporate interpersonal factors, because these interpersonal factors don't all behave in the same way, and we can't just assume that a partnership with high levels of trust will necessarily have less of a high-risk behavior such as needle sharing, even though trust is a positive interpersonal attribute. Thank you all so much.
Thanks, Maya. Fantastic. Oh my, wonderful. So we have one more speaker, and that is Julia. So Julia is already ready to go. Thank you.
Hi, everyone. I apologize in advance if you hear background noise because I have gardeners working, and I didn't know that it will be happening, so apologize in advance. But let me introduce myself. Well, thank you so much for having me here. And I'm a third-year PhD student at the University of Southern California. And I also collaborate with UCSF, with UCSF Tobacco Center, Pamela Bing, and Myung Nguyen. We see each other at meetings together. So to conclude this presentation, I'm just going to bring you all to a different world, from clinical settings to social media settings, which I don't know how many of you are familiar with research, but that's my area of focus. I study marketing of tobacco products on different social media platforms, especially those that are popular among adolescents, and also measure adolescents' susceptibility, intention to use and use of primarily e-cigarette products, and exposure to marketing or user-generated content on different social media platforms. And today I'm going to be talking about content analysis of themes in TikTok videos featuring little cigars and cigarillos, or LCC, on TikTok. So the unit of analysis here is video, and the focus of the study is just to analyze what kind of LCC content, marketing and non-marketing, we see on TikTok. And why is overall it is important to study marketing and user-generated content of LCC on social media platforms. We had platforms like that are could be considered traditional, like TikTok and Facebook, that are sort of their popularity among youth is going down, while visual platforms like TikTok, Instagram, or Snapchat, or YouTube is increasing among youth. And this gets exposed to a very prevalent tobacco-related content on social media, on these platforms, visual platforms. Many of them, actually all of them, have regulations, policies, platform policies that actually prohibit marketing or showing tobacco-related content on this platform. But despite of that, all this content is prevalent in violations of the platform's regulation. And that is definitely concerning. And TikTok is sort of stand out compared to all the other platforms because some survey analysis that we've done, preliminary analysis and already published data shows that there's a significant association between both e-cigarette use and e-cigarette initiation and exposure to tobacco-related content on this platform and just simply the platform use. And TikTok has like the largest effect. So it could be considered probably the riskiest platforms for adolescents. And so going back to the focus of this study, in this study here, to look at LCC related content, we accessed TikTok API and collected 1,500 videos that show using hashtags Swisher Sweets or Backwoods that are most popular LCC related hashtags and which generate highest number of views and engagement. We collected this post from 2019 to 2021, but the largest proportion of videos were from 2020 and 2021. After removing out of this 1,500 those videos that were no longer active, and some of them were actually not relevant to LCC themes, to LCC at all, although they were tagged with these hashtags, we were left with 800 TikTok videos. Then using an inductive approach by just summarizing visual data to a summary form and looking at the underlying themes, coders reviews these videos and develop the code book of 26 themes. And they're listed here in the results. Not all of them, but the most prevalent only. So the most prevalent themes were just LCC presence. So videos that showed little cigars or cigarillos, just their visuals. Most of the videos, 82%. 63% of LCC related videos had music in them. Over 40% had youth either displaying, discussing, or using LCCs. About 30% had humor. 30 had LCC use, regardless of who were using, youth or non-use. 28% were LCC flavors. 23 were branding, which shows logos of LCC, and about 17% were LCC paraphernalia related, then followed by blunt rolling and price. So these are the most prevalent themes that were discovered. We also conducted co-occurrence analysis, which you can see on the right-hand side, this chart. Co-occurrence analysis is the most prevalent co-occurring themes, and pairwise means that several themes could be present in one video. And on this chart, you see circles and lines, and the size of the circles represent frequency of theme occurrences that we already listed here in the results, and proximity, closeness of circles, and the width of the lines represent frequency of these pairwise co-occurrences. So if you look at the center of this chart where the largest circles are, we can see that the most co-occurring themes were LCC presence, flavor, music, LCC use, youth, and humor. And the biggest takeaway from this chart is that LCC related products were often accompanied with youth presence or youth use with music and humor. And all that creates this engaging and entertaining environment that is kind of concerning because there is a risk that the youth will become susceptible to this content and might want to use this product. So
Absolutely.
yep, we're out of time.
Sorry, Julia. Yeah, I'm afraid we're at actually 6 minutes.
Oh, sorry.
But
Okay.
I thought that last sentence of yours with that insight was incredibly important, especially as I have a preteen and a teen and worry about these things all the time. So I'm looking at time, and as I thought we would be tight on time, our session officially ends at 12. And I'm wondering how to manage the questions for our fabulous presenters. I think some of them perhaps we could have put in chat, but if you, and maybe answered by chat, if you have a very distinct question for a presenter, but why don't you go ahead if you have and unmute if you have a question for one of our presenters and just dive in with our remaining 4 minutes. I can start for Ashley, because Ashley, if you're still on, I wonder what the next step for your program is, given your insight related to the virtual versus in-person. And you're muted.
Okay, thank you. So next steps is we are actually in the works for planning another workshop, hopefully this year. And I think that some things that we're going to aim for are going to be to bring back our first responders, because they made the workshop itself so engaging. Second thing is potentially really aiming towards this being an in-person workshop only, and seeing how an in-person versus hybrid versus virtual only, those results will compare to one another is definitely going to be something to think about.
Wonderful. And I saw, Frank, you already answered a question to you in the chat. Thank you for being so on it. Anyone else want to unmute and ask a question of one of our speakers? I also saw a comment on Shivani's presentation about just the implications, the broad implications of the work you and your team have done there. I completely agree with that, just beyond even the housing and et cetera work.
Yeah, and I just want to quickly add on that. Thank you so much. And we are replicating this process in a different cohort of patients with diabetes, and Dr. Brown will actually be presenting that tomorrow during the plenary oral session tomorrow morning.
Wonderful. Thank you for that note. Good plug. Don't be shy.
I just want to like say that's wonderful to see that our trainee present the amazing research. That's great. So I just want to say that, and I want to ask Shivani actually about the tool that she used, Immerse tool, because I really wonder how we can use the EHR data to understand the tobacco use among people, the patient at UCSF, right? So in your experience, it is possible to use the method you use in this presentation to do something about the tobacco and health outcome?
Yeah, it's a great tool. It was developed at University of Michigan and then brought over by UCSF. So it's in-house. It's a one-to-one match for a de-identified medical record number. So if you have your medical record numbers for your de-identified patient cohort, all you need to do is copy and paste it, and it will extract all the clinical notes for your cohort. And then what you can do is that you can sort of play around with it. There's basic search filters where you can say, I want to look for the word smoking in my clinical notes and see how many notes pop up and on which patients they are. They do descriptive visualizations of your cohort. And then there's more advanced features, which is using in the background of the system, they're using natural language processing packages. But as a user, it becomes very simple because all you need to do is create like rules that I want to search for smoking, not another word or something of that sort. So we were interested in housing, right? So we wanted to look at homelessness, but not homeless. Does that sort of make sense? So we're not looking for the the flip.
Yeah,
of
so
it.
there's some nuance to the search tool that could be helpful for lots of applications. And I guess one comment, since we are at the 12 o'clock hour, that I would say that I learned, and I hope you all take away, is keep these names in mind and contact these folks about these unique methods. We heard about MTurk, we heard about this, you know, EHR search tool, that great visual at the end of the Julia's presentations with the circles and the connectors. I mean, my brain was exploding with all of the exciting ways that we can take what you all have done and perhaps apply it to our own areas of interest. So I encourage everybody, part of the reason for this conference is to connect people doing amazing work. Many of you trainees are our future, so you can connect with each other and connect with faculty who are on these projects and learn about these methods, so you extend the knowledge and the impact on the topic of our conference today. So thank you again, and great morning session, and then see those of you tomorrow who are coming tomorrow as well.